Hello, everybody. I'm Rob Wallace here in St. Paul, Minnesota. I'm an evolutionary epidemiologist with the People's CDC, here with my last update on the COVID-19 pandemic. While I will continue to be working with the People's CDC, this is my last COVID This Week broadcast. As I understand it, plans are in the works to continue COVID This Week with a new host. Please stay tuned. We'll be dividing my last episode into two parts. In the first part, this one, will cover global COVID and U.S. COVID. In the second part, we'll continue to track the disintegration of U.S. public health, not only through the specifics of the COVID response, but in the context of the country's, indeed the world's great divide in who counts as human enough to be worthy of material care and moral kindness. We begin with the global COVID situation. The WHO data are in terrible shape, with few countries reporting in at all or reporting in impossible zeros. WHO's minimal reporting is now up to 430,000 daily new COVID cases and 26 COVID deaths the world over, impossibly low. If we have continued to post this map of percent changes in caseloads the past couple episodes, it was to show that even in pandemic troughs or data lockouts, rebounds of any significance, there in the warm colors, can still be found, most recently in Denmark, Bosnia, Russia, India, and Cambodia. These data are impossibly low, even as media reports openly discuss the widespread nature of the explosive return of BA2 lineages like JN.1. 1 in 24 people in England and Scotland means 2.2 million people. If world public health has retreated from COVID as a matter of principle, how should we look upon these contradictory headlines? It's as if the virus did not get the memo that the emergency was over. We do see from the Economist data set of the 7-day average of excess deaths per 100,000 a flattening out toward pre-pandemic levels. No countries reporting November 18th, the last time the Economist appears to have posted, showed excess deaths beyond half a person per 100,000 population. That indeed converges upon the notion of a lesser COVID pandemic. But the Economist was also reporting that excess deaths per 100,000 remained 5% above pre-pandemic levels, even as reported COVID caseloads bottom out and total mortality measures are scant beyond the global north, making this estimate at the top less precise over time. The Economist estimates 28 million excess deaths for the period of the pandemic, 4 times the confirmed COVID death count, with most excess deaths reported in Asia. But the damage both extends beyond death alone and is now on the back end of the infection. There is little of short COVID these days. If not symptoms lingering in the months, long COVID is turning into more the norm. Your chance of developing long COVID is compounded with every infection you suffer. With that damage, and we've long reported here on COVID This Week, it's found across multiple organ systems, killing brain cells or cutting them off from blood flow or fusing neurons together, helping produce cognitive decline, affective disorders, and sleep disorders. We have pulmonary fibrosis and embolism, acute pharyngitis. We have cardiac fibrosis, heart attacks, abnormal heartbeat, anemia, micro and macro clots leading to exercise intolerance and chronic fatigue, immune dysfunction, diabetes, decline in the diversity of your intestinal flora, leading to gastrointestinal reflux and damage to the vagus nerve. Fortune here reports on a Spanish study published this summer showing a wide array of long COVID symptoms associated with damage to the vagus nerve. Quote, symptoms such as persistent cough, changes in speech, difficulty swallowing, increased heart rate, GI issues, dizziness, and cognitive complications were reportedly more common in those with long COVID compared to individuals that were never exposed to the virus or had fully recovered following acute infection, end quote. So it appears what happens in Vegas does not stay in Vegas. All the mounting and persistent illness costing people their jobs and their families with little to no support from industry or government. As we'll talk about in part 2 of our episode, the damage has been externalized onto working people. You do you, as establishment public health recommended on masking, extends to the consequences of the resulting ill health. It's all largely on the individual patient's head now. Now, much of the world is at best vaccinated for variants no longer circulating, despite COVID vaccines' demonstrable impact on hospitalization and long COVID. We see uneven campaigns and booster vaccination across the world. On the one hand, Peru, Uruguay, Argentina, and Italy show top-tier booster campaigns with 80 or more booster shots administered per 100 population. In contrast, we see near nothing in Russia, India, and Pakistan, but even those countries reporting in from Africa, as well as mediocre campaigns in Central America and Eastern Europe. This map seems like it hasn't changed much, except fewer countries are reporting in, both patterns giving the impression these campaigns largely have ground to a halt. Indeed, the CDC reports the U.S. at only 18% of its eligible population for the new monovalent booster. We can see from this time series a combination of some countries no longer reporting in, but almost a universal tailing off of new vaccinations since the spring of 2022. We've been half-assing a major pandemic for nearly 2 years now. Meanwhile, the mediocre vaccination campaigns, hand in hand with the rollback and the non-pharmaceutical campaigns that successful vaccination depends on, have been taking place alongside the continuing emergence of multiple Omicron subvariants now circulating across large expanses of the world. As of December 18th, EG 5.1 in gray-blue here is leading the way in Canada, but sharing the playing field with the return of BA2 in the form of BA 2.86 and JN.1. With other sublineages, XBB 1.16 in fern green, XBB 1.9 in aquamarine, and CH 1.1 in magenta, still holding on across these 9 global north countries. And I just noticed that the U.S. is reporting in only 101 sequences here, at least to this database. Here are a few other countries beyond the U.S. and Western Europe as of December 4th or December 18th. We try to mix in other countries week to week, depending on which countries are up to date. For December 18th, Brazil, Poland, Israel, and Singapore are reporting in mostly BA2 back again from its 2021 debut, but also lots of EG 5.1 and a few XBB 1.16s, XBB 1.9, and XBB 2.3. For December 4th, China and Japan were reporting almost all EG 5.1, with Japan also hosting a quarter portion of BA2 and all the 2023 strains except CH 1.1. Covariance.org shows BA2 strains here by country over time, surviving beyond its spring 2022 spike to roar back this October, a year and a half later. In other words, what's old is new again. JN.1 has all of those amino acid replacements we previously described for BA 2.86, but now also a serine to leucine replacement at spike position 455 that appears to offer the kind of class 1 antibody resistance that permits JN.1 the growth advantage in purple on the left that far outstrips all the other sublineages in play. Previously, the flip replacements at positions 455 and 456 in variant EG5, that is F to L in one, L to F in the other, help the spike protein bind more avidly to ACE2, the human receptor. Big picture, here's the standing global diversity of COVID genetic sequences as of December 24th and 30 days back. That the world is still hosting such a large zoo of variants makes this map green in both validity and soundness, even if not every single lineage has been sequenced everywhere it really exists. JN.1 in violet has surged this month, overtaking XBB strains like EG5 in red. Although HV1, a sublineage of XBB 1.9.2, remains prominent in the US and Canada. We still see the FLs in pink, some XBB 1.16s in green, lesser DV7s in blue, and BA 2.86 also violet in the middle. So the virus continues to change over time and space. The global zoo is also exploring a wide evolutionary space in which to experiment with attaching to the ACE2 receptor to enter the human cell as modeled on the horizontal axis and evading the human immune response on the vertical axis. Both axes are standardized relative to early BA2 scores. Now we have a change in the functional evolution here. Previously, most of the samples were of sublineages in a sweet spot of binding and escape there in the middle, the same colors from the previous diagram. But most samples now appear of lineages lurching ahead in immune escape, as in BA 2.86 and the JN.1's, or insurgent BA 2.86. A second cluster there on the left, including HV1's, a JN4, and a BA 2.86.4, appear to be evolving out in immune escape, but with lesser capacity for binding to ACE2. One can imagine any one of those on the left leading the charge to escape out from underneath host immunity before their offshoots circle back to better ACE2 binding. Now, whether that second option lets these sublineages spread across the world is another question. There are all sorts of other attributes to consider, including chance itself. The point is that this is evolution in motion. The pandemic is still very much in play. Now, the World Health Organization upgraded BA.2.86 or Pyrola and its descendants to a variant of interest alongside XBB 1.5, XBB 1.6, and EG5. When BA.2.86 arrived in August with all those amino acid replacements, there was due concern it would surge ahead. Until now, it did not, but it appeared held in check by the immune response and vaccines in play, including the new booster. But letting variants continuously evolve lets them also surge ahead when the right replacements meet the right immune opening. As CNN reports here, this is all difficult to track with the declines in case surveillance, alongside the declines in the genomic surveillance that alerts us to such threats. Yes, as the red box indicates, there's usually a lag time from isolating samples to sequencing them and uploading them. But the GIS-AID database's graph here indicates such surveillance has been in linear decline since last year, around when the Biden administration declared the U.S. emergency would be terminated in May. Although CNN also reports that the new vaccine, even though always a step behind evolution, appears to offer a 27-fold increase in antibodies that target the latest strains, including against JN.1. So get vaccinated now. Turning to the U.S., the Walgreens COVID-19 Index of National Test Positivity covers both rapid tests and PCR. As of December 24th, we see a slight decline to 26% of all tests Walgreens processes. The number of tests remain high compared to this summer, indeed doubled from just this week before, which may in itself serve as a measure of incidence. State public health departments still reporting in are showing lower positivities, although also increasing. Part of the higher positivity rate here may be that people with clear symptoms going in to confirm their infection in a way asymptomatics have largely been detracted from doing so by U.S. public health policy. But both this index and the state positivities that are being reported in are higher. We see New York, Nevada, Alaska, Idaho, and Puerto Rico with positivities up since we last looked in late November. We see the West Coast, the Southwest, and the Midwest are showing lesser positivities. New York is showing a recent decline in its time series on the right, but still appears in a quasi-equilibrium higher than earlier this year. Nevada, another example, is showing a recent peak beyond even its fall surge, but the unsteady dynamics may be due to fewer tests being reported, with this week only 75 people tested there. In early September, we reported fewer states with considerable weekly deaths attributable to COVID. Now, beyond the September surge, and now with the holiday surge, this week we see much of the Midwest, South, and Eastern Seaboard up in COVID deaths at least 4% or more there in the light green, with Kentucky above 8% in orange, and Minnesota, Iowa, Missouri, Maryland, and Massachusetts in the top, in up to the 6% category. Now, how this might reflect excess deaths nationally, CDC no longer reports, ending this work at the end of September, just as a new round of COVID-related excess deaths was being reported then, the first such surge since January of this year. So we turn to independent researchers, not on COVID deaths, but at least on cases. Infectious disease modeler J.P. Wayland is using wastewater data from BioBot and CDC seropositivity to project COVID cases per day in the U.S., with another increase to more than 1.1 million new COVID infections in the U.S. alone for the single day of December 23rd. Wayland hasn't released a detailed methodology which sets the validity here at red, although the general gestalt is probably on point. If these estimates are anywhere close to reality, both global and U.S. data should now be rated junk, and the pandemic is hardly over, especially as we described, the virus has been given the public health green light to continue to explore its evolutionary possibilities. Mike Hoger, founding director of Louisiana's Health Psych PhD program, projects us at 1.65 million new cases a day as of December 25th. And forecasts an increase to 2 million per day by January 10th. He projects us presently at 83,000 to 331,000 new long COVID cases a day. The graph remains at a red validity until we learn more about the specifics of Ogre's models. Ogre has gotten back to us that he wishes to publish first before sharing the specifics. With the CDC abandoning mapping transmission at the county level, we're forced to look elsewhere. Hubbub offers COVID prevalence per area or within a 5-minute walk by U.S. county using CDC and state public health department data. As People CDC's Andrew Wang warns, however, that Hubbub assigns 0 cases to counties that aren't reporting in. And the underlying calculations are proprietary and therefore hidden from the public, which forces us again to assign red to its validity if by dint of omission. But we could select a few sentinel states that appear to be still reporting in. Here's cases per area for New York, New Jersey, Pennsylvania, California, Florida, and Arizona, which together account for 110.5 million Americans, or a third of the U.S. population. In Arizona and California, we see Phoenix, Sacramento, the Bay Area, and nearly all of Southern California appear heated up from when we last looked at this map in late November. In Florida, nearly all population centers have heated up on both coasts. All of northern New Jersey appears hotter, as do Ocean, Gloucester, and Cape May counties in the south. Downstate New York State has heated back up, as have Rochester and Schenectady upstate. In Pennsylvania, the Philadelphia commute, as far north as Lackawanna and as far west as Franklin, appears hotter, as do Westmoreland and Beaver beyond Pittsburgh. The problems with quant data and analysis move us to take a more mixed methods approach. Against media efforts to cherry-pick on-the-street interviews to the effect that the pandemic is over, we're now collating posts from Americans who are getting sick despite the administration's declaration they're not supposed to be now that the pandemic is supposedly done. A COVID This Week listener has been collecting people's Reddit, Facebook, and Twitter posts on new infections that people are posting about. And here's a few that the listener found in the past couple weeks. I caught COVID and I feel like I'm on my deathbed right now. I don't remember it being this bad. What the fuck? Here's another longer post. I'm just shocked at how bad it is and what long haulers have had to endure. First timer, it's only been 2 weeks since I tested positive, and by all accounts, I had a mild case. Early 40s, female, 2 times Moderna, 1 booster last year. The most acute symptoms passed in about 4 days, and ever since I've been sleeping at least 10 to 12 hours a day, and then doing almost nothing when I'm awake. I've been careful not to push myself at all aside from necessary tasks. I live alone, so in some cases, I don't have a choice. I've been very blessed with excellent health for my entire life and have never experienced this level of fatigue before, but I've never doubted the long haulers. Part of the reason I didn't catch it until now is because their advocacy was extremely effective. I believed long COVID was as bad as they said, and it terrified me. So I took a lot of measures to avoid catching COVID in the first place. But at the same time, I couldn't really comprehend what their lives must be like, what their impact of the fatigue would be. It was a nebulous concept to me until now. And in 2 weeks, I can already see how quickly my life is taking on water. How many things would slip by if I were trying to work, take care of kids or anyone else. How utterly impossible it would be to rest for an extended period of time if I had more responsibilities or fewer privileges. To the early long haulers, I'm so sorry people didn't listen to you sooner. I can't imagine having to fight for myself in this state, and I certainly don't even think I haven't had it that bad. Here's another. I avoided it for almost 4 years, but recently I've been letting my guard down. Ate at a restaurant where people were coughing a lot and fell sick a couple days later. My first symptom was a sore throat. The temps dropped, so I thought it was just a cold. And then I started feeling sick and congested. And then my husband started feeling the same, but with more of a cough. And he had a physical and canceled and got tested, negative for COVID, positive for flu. So I just thought, oh, I must have flu too. And I started having diarrhea and vomiting on day 4, went to urgent care and asked to be tested for both. But they said that since I was on day 4 of symptoms and COVID lasts 5 days, there's no point in testing, even if I was positive. I would be better the next day. That is not true, by the way. Let me allow an editorial comment here. COVID is not about 5 days. That's a CDC thing that they be able to get the employees back to work after 5 days. But as this person says, they're now on day 6, and now beyond that onto day 9. The worst part since day 4 is waking up hella hot, even though it's cold, and super nauseous, and barely being able to eat without feeling queasy. I went to urgent care last night and got IV for dehydration, and finally got tested and got the text this morning that I am positive. Here's another. I'm going through a bunch of them in part because it's quite the holiday season. This is the last COVID this week from me. So going through a bunch of these is important to really give you a sense that those of you infected aren't alone, and those of you who have been lucky not to be infected should continue to exercise care. So let's see what else is what this next person says. I am up at 3 a.m. right now experiencing what is the most intense and aggressive sore throat of my life. But as in my tonsils, they're so swollen. My neck feels swollen. The pain is a 15 out of 10 right now. This is the morning of day 5 after testing positive for COVID. I've taken a hot shower, gargled hot salty water. I've sucked on so many cough drops, my tongue is burning. I've put a towel over my head and stood over a boiling pot of water. I've taken everything I need to be taking, but no, the shit is still winning. Weird because during the day, yeah, I feel my throat a little, but it's manageable. This pain, though, makes me want to jump off a cliff. I'm at war. Down with sickness, baby. Here's another. This time, COVID got me good. I have had COVID about 5 times with a little one in daycare. He seems to be the one bringing it home. My joints are killing me. No amount of Panadol and Nurofen are helping. Extremely tired. The other 4 were much milder. What the hell is happening? Here's a couple more. Here's the first of the last bunch. I had the new Novavax booster in November after 5 Pfizer jabs the last 4 years. I tested positive Monday for the first time since the pandemic started. Symptoms come on like a freight train Sunday morning. I have been severely ill now for 5 days. First 3 days, severe aches, chills, and headache like I have never experienced before. Also cough and phlegm stuck in upper chest, and have to take my inhaler every 4 hours. 4th day, throat on fire. Today, day 5, still coughing, fatigue, and feeling crappy. I got on Paxlovid immediately on Monday, which when I tested positive. I had given my doc a heads up I had symptoms, so she was ready to prescribe. Hubby brought COVID home accidentally after not being vigilant and masking at work after a work function 2 days ago. He has cystic fibrosis and recovered in 2 days. He got on Paxlovid last Sunday. I am homebound and don't go anywhere, so we are sure he got it at work. This is my 2nd time with COVID, someone else continues. The fever comes and goes. I took a shower to warm up. O2 is okay, but not perfect. It's my fault. I haven't been wearing a mask. Here's another person. It's absurd how contagious this thing is. It's the first time I get COVID. I work from home, so the only possible exposure was me last week going to the shopping center. All in all, it took me about an hour. I had my mask on 90% of the time, taking it off sometimes when I was alone in the aisle or speaking to staff, but standing 6 feet away or separated by glass panels. I always wash my hands, and yet I still somehow got COVID. It's simply absurd that COVID can spread this easily. The only times I've been sick in my life are in school or in call centers where I'm in the same room with sick people for hours, and I only got the flu once. But this thing, catching COVID from taking off my mask for a couple seconds here and there in a shopping lasting less than an hour, it's not normal. I'm worried about people with immune disorders. If I got it despite all my precautions, then most people will not be able to avoid getting it either. Thankfully, I'm vaccinated, so it's very mild. Fever is gone. I'm a bit tired, but no cough. But even for young and healthy people, I don't think it's great to catch COVID every year with the risk of long COVID. I'll definitely be more careful and not take off my mask. And here is our last testimonial, very much in the spirit of the season. Santa came early, was supposed to leave for Thailand on Thursday. 2 tests came back positive today. First time getting the goddamn fucking bullshit motherfucking fuck. God, I am so pissed off and feel like death at the same time. Now we're going to stop here and return more to more quant data, but you get the sense of abandonment, bewilderment, and betrayal represented here. And there's the self-incrimination too. It's not your fault though. The political class of both parties abandoned you in your time of need. Again, something we'll talk more about in the second part of the episode. Now, one marker of community transmission that now that caseloads have largely been abandoned is the amount of virus detected in sewage wastewater. The CDC updated its National Wastewater Surveillance System website, marking the present COVID-19 wastewater national activity level as very high. It offers a national map of wastewater activity by state. You can hover over for a general report. Minnesota's activity level here is very high, as is the case for most states across the north, which you can track over time, including this huge spike in Minnesota in orange, which might be real, but we're curious if it has to do with the switch from CDC moving BioBot off the federal contract in favor of Verily. Are they still working out kinks in the reporting? We see the levels of SARS-2 virus detected in the wastewater by sewage plant for December 3rd through the 17th across the entire country, except the Northwest. We see reporting in the oranges and reds of 60% or more of all the samples in SARS-2 detected taken nationally since December 2021. Now, I haven't seen this map this red since early Omicron. And you got to recall, we only have 1,730 of the 16,000 publicly owned wastewater plants are reporting in at all. And this week, only 1,273 reported in, with none reporting in from New York City. So again, we're just getting a snapshot here. On the other hand, the more acute measure of changes in sewage loads over the past 15 days show relative cooling off in parts of Utah and Colorado, parts of the Midwest, especially in wending isopleths through Ohio and New York, although only a little more than 1,000 plants reported in. CDC now reports SARS-2 variants in national wastewater, with EG5 in orange still ahead, but many of the other variants in play, including newly emergent HV1 in pale blue, XBB 1.5 hanging on, and JN.1 suddenly surging in purple, leaving its BA 2.86 progenitor in pink behind. FL 1.5 in light green also appears off the pot. Syndromic surveillance offers another view of the pandemic. We see from Epic Hospital reports of ICD-10 codes as of December 14th, COVID infections, positivity, emergency room visits, and hospitalizations are all back up, with infections, emergency room visits, and hospitalizations matching or exceeding the September peak. We see both RSV and influenza reports are now rearing their heads, especially RSV positivity. The CDC's county maps for influenza-like infections for the week ending December 16th shows ILI now much more widely spread than mid-November when we last checked. So especially in Louisiana, Montgomery, Alabama, Columbia, South Carolina, and Albuquerque, New Mexico, all in purple, but really widely throughout the country. They are in the dark red too. Here are the 7-day averages of fractions of hospital beds filled by COVID patients in 1,777 hospitals during December 11th through the 17th, mapped by the People CDC's Les Schaffer. That's fewer hospitals than we had reporting in through much of the summer and early fall. We see hospitals in orange across the country reporting 5 to 20% of their beds filled with COVID. We also see in reds and purples with as many as half their beds filled with COVID, more so in the Bay Area, San Diego, the Washington, Idaho region, down through the Eastern Plains, and along the along the North Carolina, South Carolina border up into Tennessee. The Baltimore, D.C. region doesn't appear as lit up as it has been over the last few months, but it appears also that many of the hospitals haven't reported in this time. Many of the high fractions may be in rural hospitals with limited resources. So, you got like 3 beds filled out of 5. But others are indeed large medical centers. So, for instance, Schaffer reported in November that Palomar Medical Center in Poway, California, had 25 of the 53 beds filled. Palomar Health in Escondido, California, had 62 out of the 230 beds filled. Now, here are the county hospitalizations per 100,000 population as of December 19th. We see much more spread to the plain states, especially Nebraska, west into Montana and Wyoming, and east into the Midwest. U.S. News and World Report reports that the U.S. hosted 23,400 new COVID hospitalizations ending December 9th, a 3% uptick from the previous week. But that's probably since exceeded given the holiday season, and also leaves out the many truly ill who haven't made it to a hospital bed, that even if they do indeed need one. Here are our top 10 counties, with the first 2 far exceeding the top county in our November check-in, which was at 50 per 100,000 population. We have here Richardson County, Nebraska has 66.8 out of 100,000. Pawnee County, Nebraska has the same. Washington County in Kansas has 46.3 out of 100,000. And to go on through the rest of the list, so you get a sense of where else: Marshall County, Kansas; Valley County, Montana; Roosevelt County, Montana; Letcher County, Kentucky; Norton County, Kansas, Smith County, Kansas, Phillips County, Kansas. So all along the plains states are really getting hit hard in terms of the hospitalization. Now, here are the 7-day sums of pediatric COVID admissions over time, summing up for all reporting hospitals across the U.S., again, as graphed by the People's CDC's Les Schaffer. We see the spike in early Omicron, putting the lie to the notion that COVID doesn't hurt kids. We also see that we are now exceeding the smaller spike in pediatric admissions there in September. So it's much more so here now in December. Schaffer also graphs 7-day averages in adult hospitalizations. They are in red, confirmed cases in blue, and confirmed deaths in green. To see whether they tracked each other or whether they didn't, and depending where. And this is across all 50 states, arrayed here in alphabetical order. And so we found in some states like Mississippi, they did indeed track, while in others they did not. And one can imagine that those states with lower hospitalizations but higher cases might indicate a decline in COVID virulence. But those states, including Connecticut and Massachusetts, with higher hospitalizations but lower cases and deaths, were likely engaged in underreporting. Now, hospitalization, that's the only one of the three here that's still being openly reported, appears to be up across many states, including Arkansas, Arizona, Colorado, Connecticut, Iowa, Idaho, Illinois, Indiana, Kansas, Kentucky, Massachusetts, Maine, Michigan, Minnesota, Maryland, North Dakota, Nebraska, New Mexico, New Hampshire, Ohio, Pennsylvania, South Dakota, Utah, Vermont, Wisconsin, West Virginia, and Wyoming. So a lot of states have increases in hospitalization, and such reservoirs they serve as reservoirs for new surges that can spring out of such states when they're routinely hidden by national level data. Now, the outbreak stateside continues to evolve, with here a broader mix of sublineages in play, including in order of prevalence, JN.1, HV1, JD.1.1, which are 3 of the 34 that are being listed here. And these are splattered in different combinations across the country. Here's the 30-day trend of all the genetic sequences of detected sublineages in the U.S. as of December 22nd, including their geographic origins. We see HV1 still leading the way at a quarter of the samples as in the CDC distribution, but they're in decline against the surge of JN.1. We see newbie JD1 emerging in New York and California, spreading in characteristic fashion to other states from there. Molecular biologist Richard Cow reported in October this new JD.1.1 clustering with HV1 in an antigenetic cartography, which is a map of how the strains respond to antibody inhibition. So JD.1.1 with HV1 and JN.1 clustering with its BA.2.86 progenitor. And Cow reports that HV1 and JD.1.1 are more antibody evasive than FLIP, but display lower ACE2 binding too. And as we previously talked about early in the broadcast, L455S and L455F are called FLIP mutations because they switch the positions of amino acids F or phenylalanine and L or leucine on the spike protein at amino acid position 455, increasing SARS-2's transmissibility. But the thing is, JD.1.1 exceeds even that evasion. So we have to keep an eye on that at a time in which JN.1's doing very well. The worry now is whether JD.1.1 is going to do even better. So we see propulsive COVID evolution at a time when few of the potential population has been vaccinated with the new monovalent vaccine we previously described, offering excellent protection, including against JN.1. NBC News reported only 3.5% uptake as of late October. We're now at 18% today. In announcing the end of the pandemic emergency in May, the Biden administration declared, we have the tools to fight the virus. But if no effort is made to get people vaccinated, and instead, as we reported here previously, spinning off those tools to market pricing few in the country can afford, how are we going to keep the as many as 331,000 projected daily new long COVID cases from getting so sick? And so we'll explore more of these sociopolitical barriers in the second part of the episode. And that's the first part of our COVID this week. You can find our second part linked in the video description below. You can find all our episodes on the People's CDC YouTube channel. And you can learn more about the People's CDC and read this week's COVID weather report at our website, peoplescdc.org. census.gov.org.